Get ready to get smart on education and attitudes in ophthalmology. First up, from surgeon to artist to maverick. Are you ready? A Gulani masterclass by Dr. Arun Gulani out of Florida. Peace and trauma in the mountains of South Africa by Dr. Sanushka Moodley would be next. Dr. Moodley is also from South Africa. And third, the alternative glaucoma toolkit, chocolate, tea, and meditation for disease control by Dr. Sahil Thakur out of India. Well, this is proving to be a very lively session. Let's get ready and get cracking.
Hi, I'm Dr. Gulani. Today I'll share with you how I teach my masterclass and the concept of how there are 5 levels at which I want every eye surgeon to be at. You being a surgeon is wonderful, but can we make all this rise up to artistry, make you into a maverick, and then are you ready for that? So here we go. So in my masterclass, I like to break this down into the following 5 levels. You know, when you see surgeons doing surgeries, doing excellent rexus on a white cataract, able to play with a subluxated cataract, stitch a secondary lens or glue a secondary lens into the sulcus area, or perform corneal techniques, and all of that stuff, and various levels of keratolenticule refractive surgery, it's still technical. There's a surgeon level I'll talk to you about, and then there is an artistry level, then it's a vision architect, and then you become a maverick. So let's talk about this. So with all these surgeries that you see me do, like in these cases, we are showing you straight from corneal surgeries like intracorneal implants or rings to stabilize corneas and extreme keratoconus and ectasia, or lamellar corneal surgeries like in these patients that you can see, where we're using different levels of corneal corrections, even of LASIK, SMILE, PRK complications, automated 8-bite anti-toric lamellar techniques, or even no-stitch lamellar techniques, and we take these patients to straight vision, or doing pterygium surgery, removing these massive pterygium with my 3-step technique that I've described before, or doing white dense cataracts with floppy iris or iris hooks in RK cases like these with premium lenses, or doing through multiple corneal surgeries, your perfect rexus, and doing your surgeries in a sublux cataract. All that is still technical. Here you can see various ICLs coming out in different complicated cases, or putting in piggyback lenses, or correcting triple and quadruple lenses that I've seen removed from patients' eyes that I've done, as you can see here. And you can even see patients where we've gone through their RK and corrected their lenses, different kinds, or in patients like these, and a surgeon where you can see me putting a second lens in the eye and then removing the first one, atraumatic through the incision, no stitches again. All these are still techniques. All these are still techniques. It shows your technical level. And you can see the outcomes is exactly what you want, even in these RK cases with these procedures. Where it rises beyond that is once you start with extreme empathy, commitment, and performance, where each of your patients, as you've seen me in every teaching, I show patience, because there is no higher level of accountability or success. You cannot just show a video of some surgical circus and not show the patient. The patient may still be blind or be extremely unhappy with what was done. Or a chart that you show a good topography, but the patient's vision is still not 20/20. So once you have extreme empathy, commitment, and performance, now with your technical skills, it's a surgeon. Where does the surgeon spend their time? Not in technology hype, but first deciding vision, then going into technique or surgery, and finally picking the technology. Here's where I spend my most time planning these surgeries, as you can see, individually for each patient, because that's your hallmark for empathy, compassion, and performance as a surgeon. So you can see here again your technical skills, not only in every white cataract that you're getting a perfect rexus, perfect 20/20, but in the empathy of how these patients come to you, how they're flown to you with extreme disabilities of these cases, and then you celebrate how they leave your practice with amazing vision and full independence, as you can see. Right? So that's what makes you a surgeon. Patient like this from South Africa with nystagmus with extremely high hyperopia, extremely high astigmatism, written off as nothing can be done. You design instruments to control the eye during your laser plastic surgery. You just don't give up on these patients and are still very accountable. You actually make them see 20/20 from being told that they were impossible, and then celebrate with them. That's a surgeon. With patients like these with extreme radial keratotomy, very high hyperopic astigmatism, corneal scars and cataracts. Again, not only are you adapting new technology, like in this case, we are injecting the intraocular steroid right there without any drops, so dropless surgery. But in these complex cases too, you're empathizing with the patient besides technology to perfect vision. So when you take that now, the surgical abilities of yours, besides the technical skills and surgeon, and you raise it to comfort, elegance, artistry, ambiance, now you're an artist. So look over here, you can hear this patient.
I'm enjoying your light show.
I'm in his eye. This gentleman from Abu Dhabi with multiple failures of surgery, and all my patients, as you can see, no anesthesia, just drops. And this is the night of his surgery. He hired this bike for me to sit on before he took his flight back home. So it's very important how you do these things. See these patients, this is a very serious Coast Guard with multiple radial keratotomy complications right out of surgery with his vision. Or here are patients with extreme intraocular corrections that I've done. Look at them walking out, no stretcher. No stretcher. Look at the ambience. Look at their reaction. This is where you become an artist. Not doing transplants or any barbaric surgery. That's easy for you. Always think about the patient. See how these scars are removed by laser plastique, not PTK, refractive laser plastique straight to vision. Taking pterygium and pinguicular and ocular surface surgery to extremely sparkling white eyes with full safety. Look at the patient's reaction.
You are the freaking best.
This is the next day after surgery. Extreme recurrent pterygium she had before she was sent to me.
I mean, thank
like
you
all
so
our
much,
patients
my
that I've
kid.
shown you.
Thank you.
Thank you, Doctor.
Thanks.
So very important. This is artistry. Not only are you doing surgery at a high level, but you can celebrate with them. The artistry also combines into the instruments you design, the scrubs you wear. It's the entire ambiance that you create without a show. It's part of who you are. In my case, I constantly blend both my passions of surgery and fashion. As you can see, this is a full day of wearing a purple color, right from giving my talk to performing surgery to teaching to showing up on the fashion show at night or designing instruments. So it's all important to me as part of the system. Now, that artistry, if you take into minuets of your artistry, meaning pieces like Lego pieces of your work, and you can now work on that as a vision architect. For example, take this patient who was in a lawsuit with his surgeon because they had done premium cataract surgery in keratoconus, and they landed with farsightedness, high keratometry, central scar, and on top of that did a YAG capsulotomy. So the premium lens was now with an open bag. All right. So if you look at all this in my 5S system, the issues I had was farsightedness, high keratometry, anterior corneal scarring. And how do I correct all of this? Well, there's one surgery that can correct all 5 of these elements. That's myopic laser ablation. The problem is this patient was hyperopic. So now see how this entirely complex case that was in a lawsuit. One is I could just be a bravado showing my surgical skills, exchanging the lens, doing the vitrectomy, but that doesn't bring you to 2020. That wouldn't allow him to go back and be a pilot. So you have to think that way as an artist. Can't just do barbaric surgery, make a video and show off about blood and vitreous everywhere. Focus on the vision and see how you plan. So to make this patient myopic, I had to do a surgery on this patient, which would make him myopic from hyperopia and all these other issues he had. And that was a piggyback lens. So we did that. Now I call this going to Iceland before going to Paris, even though the promise was Paris. So from here, when I put a piggyback lens, his vision actually deteriorated, like I took him to a dark, icy Iceland. And then next stage I did was with laser plastique, correcting all his errors of myopia, scar, and high keratometry was decreased, increased optical zone, and corrected the pseudophakia. All to 2015 vision, actually. He went back to being a pilot. Here are patients where you can combine. Again, you're seeing the vision architect concept. How I've taken laser plastique, corrected the scar, never PTK, laser plastique, which is refractive, and then put in a toric premium lens straight to 2020. Here's another patient from Switzerland where we did a combination of intacts in the eye, followed by toric lens, and you can see her straight to 2020. She went back to Zurich. Here's another patient. He's actually a surgeon. You can see the dense RK cuts, over 20 with peripheral AK cuts, nearly 30 cuts in all, with blinding central scar with a cataract. So you can see me here following my principles I just taught you. As I first look at this patient and decide how do I prepare. Look at the cornea here, over 15 diopter astigmatism, very high case, keratometries. And I did a hand lamellar because no machine can do this. Hand lamellar keratoplasty in this patient. I'll go a little fast to make up for time. Excellent. And you can see here now, as I go through this cornea, it's literally in pieces. That's why it had the scar in the first place. And I'm doing my very gentle dissection. If I go down, I'll tear. If I go up, I'll tear. And I'm doing a hand lamellar surgery. I prepare this patient with the hand lamella surgery. It was very difficult stitching because I'm very particular about my anti-torque, but I had to go through different RK cuts as I'm picking up the remaining tissue, which was all in pieces. But you're adamant about being an artist. Anyone can do a penetrating transplant. You want to perform artistry. So here's the patient now, and you can see the pre and post-op right there. Here you are, pre and post. And now, with high confidence, I even go and do a premium cataract surgery. Again, no stitches, and the patient lands at 20/25 vision. Again, look at how the surgeon reacts right out of his intraocular surgery. Very important. That's what makes you a vision architect. You can see the sequence of this surgery from dense scarring RK to cataract clarity and then pseudophakia. Here's a patient with 9 previous surgeries and hexagonal keratotomy with ectasia. And you can see here, patient from 23.5 diopter astigmatism and over 89 diopters of keratometry. So we started by first doing an intact. And then from there, I went straight to, you can see the keratometry, you can see the topography right here now.
Along with associated cataract and high keratometry of 88.
Here we go. You can see over 89 diopters here, over 23.5 diopter astigmatism. Here I'm putting my titratable intact technique, manual. So you want to dissect it without tearing in front or tearing into the hex K in the periphery. And you see me do that, and I'm doing it watching my central reflex that you can see. I call that reflex central circle of sight. So you see that I'm doing 2 rings so I can stabilize this very unstable hexagonal keratotomy island of this patient with 23 diopter astigmatism, 23.5. Having done that, you can see the central reflex is becoming a perfect circle, and that's when I know I got it. And we actually brought this patient down to 1.4 diopter astigmatism with just this surgery. And because the center is clear, remember my structural concept, we don't need any transplants or lamellar surgery, and we cross-link the patient immediately because I'm very happy with what I've received. And brought the patient to 1.4, measurable cornea. Now, you can see the patient dresses up after 60 years of blindness to celebrate with her. And now I'm going to go through this, hex K, intacts, all her previous surgery, and do the cataract surgery. Again, we want artistry, no stitches. You want to be perfect. We measured her, remeasured her. I'm going in with a premium lens surgery in this patient. You can see the manual rexus. You don't want to take any chances of automation here, which may not go through the way you want it. So you have to be very confident. And the patient, remember, like all my patients, has no other anesthesia besides numbing drops. So you're doing all this while you're chatting with her, and you're able to perform because you also are giving the experience, the ambience of surgery. And here we are putting in a premium toric lens straight to 20/25 vision. It's very important how we now, you can see her use of technical surgical empathy, artistry, vision architect, and the end point we are celebrating with these patients. So no matter how complex they are, you're seeing the minuets, you're using the pieces and Lego pieces of your skills in stages in these patients to conquer their very poor vision. And you can see her, she actually went back to becoming a nurse. Completely free, happy, became a nurse and helping other patients like her. So here's another patient of previous 12 procedures that had failed in keratoconus. Patient had PRK, PTKs, multiple cross-linkings, intacts. You can see the ICL, now cataract. Just left off for being blind. Nothing can be done. There is no such thing. So we first corrected the corneal scar with laser plastic, made him measurable, left the intacts in even though I didn't like the way it was done, but it was at least stable over the years. So I'm going to use that stability to my advantage. And then we go inside the eye. You remove the ICL, like we do in cases like these. Disregard all the other surgeries because your measurement's very accurate. And then you remove the cataract after this, but leave the patient aphakic because you're not confident of any machine measuring these patients' lenses. A week later, you go into the eye and put in your premium lens with full confidence. Again, no stitches. You saw me use the sealant right there. And you want the patient to be free, and they are with 20/20 vision till this date, 8 years later. So you can see the sequence of how we went through that system. So the whole concept here becomes, you can take now this level of your vision architect concept and now rise to becoming a maverick. You see this patient from Egypt with multiple surgeries, numerous cross-linkings and keratoconus surgeries, including the carotid, and you can bring them straight to vision. Patient with multiple previous premium cataract surgery, then had laser scar, hyperopic surprise, wanting to sue her surgeon. We did the correction of the scar with laser plastic, then put a piggyback lens to correct her straight to 20/20. Again, surgeries took 3 minutes and 4 minutes, all topical. Here's a patient with extremely high myopia and astigmatism, ocular albinism, and extremely high keratoconus over 11 diopter astigmatism. Again, no worries. Use your logic and knowledge. And you go straight into the eye, do a refractive lens exchange with perfection, cancel all the optical errors. So when you reach that level where you can take any train wreck that is referred to you and top it, not just stop it, take them to 2020, have that mindset, then you're becoming a maverick. You can see any level of cases sent to you. As long as there is visual potential, you can fight for them. So then there is no limits for you. You look at any topography, any refractive error, all your patients experience the same concept. Your technical levels are amazing. Your surgical empathy, compassion is always there. You're performing like an artist with surgeons, doctors, industries watching you openly and transparently. And the patient enjoys the experience right from during surgery to post-op and for the rest of their life. All right, you can see here again the relation with patients that you can have, how they dance and have fun with your patients having TikTok with me. She's a national ballroom champion who had very high regular astigmatism, but why not? Why not? That's the level I want every surgeon to be at. So it's very important, like I said, having the skills of talking about your surgical skills and transplants and doing a rhexis or doing a white cataract, sublux cataract, putting a secondary lens in the eye, doing different corneal techniques or whatever. That's technical. Please rise to surgeon level, artist level, vision architect, and then become a maverick. That's the G-star level. I would love for everybody to aspire for that so your patients can really enjoy what they deserve, and you too. And you would love the way to practice. The side effects of being a masterclass maverick is you don't need to advertise. You don't need to market or schmooze. You work on your terms. There's no jealousy from colleagues or anxiety of the future. No pressure from industry. You weave your passions into your work like fashion and eyes in my case. Enjoy your patients and staff. Teach selflessly with no expectation. And really, truly be the doctor. That's my most important lesson to surgeons. Is not to keep talking about surgery, but actually deliver, perform, and show the empathy and compassion. Then your patients will talk about you, as you can see. Yes, this is a high price I pay. Patients can write anything they want because none of them is incentivized, and in my practice at least, I don't advertise or market, but your patients will talk about you because they went through all those levels. And you are at that level where you inspire everybody to explain or express their joy. All right? So I would encourage you all to please rise. Let's go right up to the maverick level, and I know you can. For you, Dr. Gulani.
Hi, everybody. I'm Sanushka from South Africa. Just loading my talk. Dr. Gulani just gave a wonderful talk. It's going to be a hard one to follow, but I'm going to try my best. So this talk is basically about reflecting on a time where I worked in a rural setting in South Africa. I have no disclosures to make. So just to give you a bit of background demographics, South Africa's population is just over 58 million. We have quite a high unemployment rate, almost a third of our population. And our life expectancy sits quite low at 64 years. Funny enough, this has dropped in 2 decades. And as you can see, the top 3 causes, the third cause is injury and violence. So just to show you what our big cities look like in stark comparison to the rural areas, this is Cape Town. We all would have met here for World Ophthalmology Congress last year, if it wasn't for COVID. Cape Town has been voted the best city in the world 7 years in a row by the UK Telegraph. And for obvious reasons, it's a stunning city, beautiful coastlines, beautiful landscapes. It's known for its wine, its beaches, and it can compete with any first world country. It's our comparison to sort of Los Angeles. And then we have Johannesburg, which is our comparison to New York kind of setting. It's our concrete jungle. It's our financial hub. I live in Johannesburg. Johannesburg is also the largest man-made urban forest in the world. There's about 10 million trees in the urban area. And this makes it quite a green, eco-friendly city. And Sandton within Johannesburg, 120 years ago, was the richest gold field on the planet. And today, fittingly, it's the richest square mile in Africa. So I work in Pretoria, which is about a 30-minute drive from Johannesburg. It's our capital. This is where our parliament sits. And it's most famously known for its jacaranda trees. It's known as the Jacaranda City. And from September to November, it's basically painted purple with all the jacaranda flowers. So in stark contrast, as you can see, we've got the OR Tambo district, which is on the east coast of the country, very underdeveloped, completely untouched. I always used to think it would remind me of one of the islands Jurassic Park was shot on. Rugged coastlines, stunning waterfalls. There's so many waterfalls and so many of them that drop directly into the ocean. And it's not unusual to see the cows visiting the beach every day. So the OR Tambo district, it falls within the turquoise area on the east coast on the map of South Africa. It was formerly the area known as the Transkei, and this was an unrecognized state between 1974 and 1994 by our previous apartheid government. This land was given to Black South Africans of Xhosa descent, and it was said to operate independent of South Africa, but the UN obviously didn't recognize this as a true independence. They rather saw it as a sham independence just to sort of maintain segregation. And as a result, it's very underdeveloped, it's very untouched, and more of 60% of its population fall below the poverty line. It's famously known as the birthplace of Nelson Mandela. He came from this village in the middle over here called Mveso village. And in the bottom picture, you can actually see, you can see him standing in his childhood home. It's also known as the Wild Coast for obvious reasons. It's very popular for hiking and outdoor activities, and the coastline is scattered with many backpackers. It's very popular amongst European students taking a gap year before they start their studies or before they go into the workforce. And economy is driven in the form of small-scale farming. This is the town where I worked. It's called Lusikisiki. It was up in the mountains just above the coastline. The actual town only has two main roads, and the town itself consists of a few municipal buildings, a banking building, some schooling, and a few shops. And then there was a primary level care hospital. It's very common to see women like this with the buckets on their head going to fetch water from the riverside. And many of these homes are run by females. And in the top left, you can see middle-aged to elderly women actually selling their baskets that they've weaved or beadwork. And this is how they make their income. In terms of housing, you can see at the bottom, there's relatively informal housing. You've got some cement houses, but they're generally 1 or 2 roomed houses. And then you've got the traditional huts, which you see on the bottom right. And these are what we call rondavel huts. It's essentially just one room. So just to give you a comparison in terms of the statistics between the rural and urban areas, you can see the OR Tambo district has a population that's more or less half of the bigger cities. And in terms of the mean annual income in South Africa, this is about $2,000 per year. The OR Tambo district population earns less than $1,000 per year for a household. And in terms of unemployment, almost 40% of people living there are unemployed. Very few people complete their schooling or have any tertiary education. And in terms of formal housing, as mentioned, there's only 30% of people who actually have formal housing. Piped water in the household is only 10%. Flushing toilets in the house is only 19%. And with regards to electricity in the household, only 72%. So this is the hospital where I worked, St. Elizabeth Hospital in Lusikisiki. This is a primary care facility, as I mentioned. They basically treat general surgery patients. They have an obs and gynae facility, a medical ward, and a pediatric ward. I started an eye clinic in this hospital with an ophthalmic nurse, and we basically used to screen any sort of tertiary level or surgical patients to send to the tertiary center. And we also were the first line of call for any trauma seen in the casualty. This is the tertiary level hospital, Nelson Mandela Academic Hospital. It's about 90 kilometers away from Lusikisiki, and these were the nurses that head up the eye clinic there. This hospital also has about 3 consultants and about 2 or 3 residents that run this department, but it's basically doing general ophthalmology and not really subspecialties. So the types of trauma seen in the OR Tambo district were mostly alcohol related to non-accidental injuries. And most of the time the assailant is known. It's either a friend or a family member, which is very sad. Penetrating trauma is more often seen over blunt trauma, but I think this is also largely due to the fact that blunt trauma patients just don't present themselves if their injuries are minor. And the weapons most commonly used were knives or bottles, and generally broken bottles, which are quite sort of disfiguring weapons to use. Severe morbidity and blindness is more related to late presentation of patients because of this rural setting. Patients live very far from the specialist centers, they're not operated on site, and obviously referral is dependent on ambulance availability. So with regards to blunt trauma, like I said, very few cases that we saw in the time that I was there. These patients were both assaulted with a closed beer bottle. The gentleman on the bottom left just sustained a soft tissue injury with a lid abrasion. He was lucky not to have any globe involvement. This lady here, she lived very rurally. She was attacked by her husband with a beer bottle, and she presented with an orbital cellulitis from an orbital floor fracture that she sustained from her injury. Gender-based violence is also very common in this area. Penetrating trauma with regards to lid injuries, you can get all kinds of lid injuries with the beer bottle. Margin involving, they can be sort of very simple lacerations or very complex ones, like I'll show you later on. But these patients were all lucky enough not to have any globe injuries. With regards to penetrating trauma, a bottle does quite a number on the eye. The lady in the top had a stellate corneal laceration, basically like a starburst in the center of her cornea. These two gentlemen basically have corneoscleral lacerations as well. The gentleman at the bottom actually had a medial laceration from the bottle with a scleral laceration posterior to the equator. And this is not unfamiliar sight. You usually have patients coming in with the weapon still in their orbit or on their face. These are two teenagers who were both under the influence at the time of their injuries. The teenager on the far left came in with the knife going through his orbital floor, sitting in his maxillary sinus. Lucky for him, there was no eye or lid involvement. And he basically came away from this with his vision fully intact. The teenager on the left, on the right, sorry, is even more lucky. He had a rod stuck through his orbit. And if you look at the CT scan over here, you could see the globe is actually intact. He basically sustained a fracture of the right inferior and medial orbital walls. And he was just really, really lucky not to have a life-threatening or sight-threatening injury. And then, as I mentioned, these bottle injuries or injuries can be quite disfiguring. The two patients on the bottom were both injured with bottles. And what happened with them is that they were stabbed with the bottle and then the bottle was rotated. So very, very devastating injuries, complex lid trauma. And both of these patients ended up with disorganized globes that needed to be eviscerated. The gentleman on the top was stabbed with the type of bush knife. This bush knife went through his closed eyelid and completely destroyed his eye. And the tip of the knife was actually sitting through his palate. This is one of the worst ones I saw. The mechanism of injury was penetrating with the use of this knife, which is called a panga. It's a bush knife or used for harvesting. This gentleman was attacked by a friend who was also under the influence at a time, and he was sleeping. As you can see, he's actually cut right across both of his eyes, and his eyelids were actually closed. So these lacerations are through his upper eyelid, and both of his eyes were bisected. He actually lost both of his eyes. The gentleman on the top right was lucky enough only to have a unilateral injury. This is from a separate incident, but the same weapon. And lucky for him, he had a minor sort of corneal laceration that could be repaired. So as you can see, there's a strong relationship between trauma and alcohol in South Africa, particularly in this area. And with all of these headlines, they're actually from COVID. COVID actually highlighted the fact that South Africans have or trauma in South Africa is strongly related to alcohol and creates quite a burden on our healthcare system. At the start of our sort of very strict lockdown with COVID last year in March, alcohol was actually banned, and all of the hospitals saw a significant decrease in the amount of trauma seen. And the reason why the government did this was to sort of keep beds open and keep doctors available to manage COVID cases. And as these bans were lifted, the trauma just came streaming in again. So there's definitely a strong link between the two. The paradox when it comes to South Africa's drinking culture is that while the majority of adults abstain, those who do drink so heavily, and the WHO actually classifies the majority of the drinkers in the country as binge drinkers. So if you look at this case of beer, this is a case of beer that one would particularly drink. It's very cheap. A case of 12 750 ml beers sells for about $6. So very cheap, very available, and obviously socially acceptable. South Africans consume more than 6 billion liters of alcohol per year, and alcohol abuse costs the government about 9 billion per year, which obviously exceeds the revenue collected from alcohol tax. Often alcohol abuse leads to drunkenness and violence, and a high level of alcohol misuse is reported amongst residents of disadvantaged communities. Intoxication is a major factor behind high percentage of motor vehicle related accidents and incidents of interpersonal violence. So just to give you an idea, between two different ophthalmology departments, this one is based in UCT, the University of Cape Town, and then the rural one is based in East London, which is the sort of biggest city located next to the Transkei rural region. At UCT, the study was conducted over a 2-year period. They looked at 398 emergency ophthalmology admissions, and 63.7% of these were open globe injuries. Of these injuries, almost 65% were under the age of 35, and the open globe injuries due to assault was 73.5%. In assault-related open globe injuries, basically 51.9% of assailants reported to be intoxicated, and about 66 patients admitted to being under the influence at the time of injury. Assailants, like I mentioned, are generally always known. So 65.5% of friends are friends or acquaintances. You have neighbors over there, you have spouses over there, and even family members. When we look at a rural ocular trauma study that was conducted, this was looked at over a 7-month period. They looked at 154 eyes from 152 patients. 83% of these patients were male. The household was the most frequent setting. So once again, the assailants were known. And from the non-accidental injuries, 83% were related to alcohol consumption. There's a higher proportion of open globe injuries, and the most frequent offending object was a knife. Trauma is the leading cause of death in this Transkei OR Tambo region in South Africa, which is one of the least developed parts of the country. The unusually high level of crime in this area is a reflectance of the massive unemployment, poverty, and low-level education in this area. And the observed rate of violence and traumatic death is about 2.4 times higher than Cape Town, and alcohol remains one of the most commonly abused substances amongst trauma patients. So in summary, there's still a significant disparity across all spectrums between urban and rural living, and this is potentially a driving factor for alcohol abuse in these communities, which can potentially result in trauma. The COVID lockdown has emphasized the impact of excessive alcohol consumption on our healthcare system. And the regulation of alcohol consumption, albeit controversial, is necessary to reduce the amount of trauma we see in South Africa. Thank you very much. That's me. I'd like to now hand over to our next speaker, Dr. Sahil. He'll be talking about the alternative glaucoma toolkit, chocolate tea, and meditation for disease control.
Thank you so much, Sanushka. I think that was an excellent talk. After starting out with the beautiful scenery in South Africa, you did show some complex and horrifying images of what humans can do to each other. But again, if you get treatment at the right time, a lot of these cases can have acceptable outcomes. Anyways, now I'll be starting my presentation. Okay. So the topic that I'm talking about today is the alternative glaucoma toolkit. I'll be talking about chocolate, tea, and meditation and how they can be used for disease control. So I'm currently a clinical research fellow in Singapore, and I have no financial or commercial interest in the material that I'll discuss in this presentation. So glaucoma, as we know, is a disease that has a huge magnitude. It's a chronic disease with no cure. All we can do is contain and prevent the disease progression by controlling the IOP. It has a significant impact on the quality of life of the patient. And despite good IOP control, progression still occurs in a lot of patients, about 20 to 25% of our patients. And what's more alarming is that the rates for persistent of treatment are generally below 50% at 1 year. So this tends to be seen more in rural areas as compared to the urban areas. Coming on, if we see the global percentage of money distribution across the world, what we see is that across the world, most of the population actually lives below $1.90 a day. So again, we know that we have a lot of advancements right now in the glaucoma scene. We have OCT machines coming in that can diagnose glaucoma quickly. We have new medications. But in this talk, we'll talk about something different. We'll talk about something that is low tech, something like chocolate, tea, and meditation, and how they can supplement and complement the glaucoma treatment. So initially, we'll start talking about chocolate. I hope you all are drooling with these images of chocolate. The chocolate that we are especially interested in is dark chocolate. The active compounds, they have done some research, and it appears to be that theobromine and phenylethylamine are the active compounds that are the ones that we are most interested in. In addition to these, all form of chocolates also have flavonols, iron, copper, manganese, fiber, protein, and calcium as well. So initially, chocolate has been tested in a lot of systemic diseases. So these are two reviews. So the chocolates have been shown to reduce the low density lipoproteins, also the total cholesterols. However, they don't affect the HDL and the triglyceride levels. In this study, which was a randomized controlled trial, what they saw was that even a 40-gram bar of dark chocolate versus controls in 22 heart patients, even after 2 hours, the coronary diameter, it increases, the coronary vasomotion also increases, and platelet adhesion decreases. So the effects are quite often seen very quickly after the intake of chocolate. So people have also compared dark chocolate and white chocolate. So what has been seen is that most of the benefits that you can get from chocolate are from dark chocolate. So especially in this trial that was done to see that memory performance improves with dark chocolate. And moreover, dark chocolate can also improve coronary flow velocity reserves when compared to white chocolate. So taking this information means that if we are going to recommend chocolates, it's preferable to recommend dark chocolates instead of the white ones. Coming on, in ophthalmology, there was this very interesting randomized control trial in which they compared a 100-gram dark chocolate bar with a 100-gram white chocolate bar. The patients that were there were 18 healthy subjects. However, in this comparison, they could not detect any difference between the two groups. However, as we can see that the sample size is quite small. So this study was actually done recently, but this was in follow-up to this original study. So this study that was published in 2014 had 30 glaucoma patients and 30 age-matched controls. And what they saw was that there was significant dilatation after ingestion of chocolate in the retinal vessels. And this was especially seen more in the control group. We can see that there is a trend in the glaucoma group as well. But again, in box and whisker plots for small number of patients, quite often the benefits of such an intervention are difficult to observe. Coming on to tea. So for tea, again, a lot of research has been done previously. Tea has been shown to help with coronary flow velocity reserves. It has also been shown to help in blood pressure control. Also, in a recent study, what they showed was that green tea can actually affect and improve the deleterious cardiometabolic effects of 7 days unhealthy lifestyle in humans. So in this, what they did was for 7 days, they gave the subjects a diet of burgers, Coke, and cola, and then they used green tea to measure the effect on various biological parameters. So tea is a very interesting subject, and this was a Cochrane review, which kind of shows that black tea, green tea, they both have individual differences. All of them can reduce the LDL, they reduce the total cholesterol, and they also help with blood pressure control. So if you see in the blood pressure control, they lead to a reduction of minus 1.85 mmHg. This is quite significant. Why? Because even some of the drugs that we use only show reduction of 2 to 3 mmHg. So tea drinking can be quite a good alternative to routine drugs for blood pressure control. And both of the cholesterols, important thing to note here is that the HDL is not affected. So what that means is that the protective component of cholesterol is not decreased. Coming on to this study, which is one of the largest studies that has compared a different consumption behavior of coffee, tea, and soft drinks. So this is from the Nanes group. They had 1,678 participants. So in this study, they found an association that 1 cup of hot tea daily, those people who had that had a 74% reduced odds of having glaucoma. And they could not find any association with coffee, iced tea, decaffeinated tea, or soft drinks. So this shows that in population-based studies, we have quite strong evidence that drinking tea can actually prevent glaucoma. So someone would ask, is there more evidence on coffee? Some people don't like tea and they would prefer to drink coffee. So we'll discuss a little about coffee as well. So for coffee, this is one of the original studies or the first studies that was done on coffee to see how it affects intraocular pressure. So this was in 13 glaucoma patients. Why I'm showing this is because over time, mostly this is the effect that has been seen. So what happens with coffee and tea is that once you drink it, there is a mild increase. Over time, the eye pressure from coffee, it remains increased, whereas from tea, after about 90 minutes, there is decrease in the intraocular pressure. Subsequently, 6 RCTs were meta-analyzed, and what they showed was for normal subjects, there was no change in the IOP profile. However, for glaucoma, the IOP increases after caffeine. So in this case, most of these studies had people drinking coffee when they were measuring the effect of caffeine. Coming on, what we also see is that coffee has a dose-dependent effect. So when we compare 182 milligram strong coffee with a 4 milligram decaffeinated or reduced caffeine coffee, the IOP and ocular perfusion pressures, they increase more with the higher dose. However, what's startling to see is that in this recent study, they showed that caffeine can also cause angle narrowing. So that means that it also has a structural effect. And this is probably one of the reasons that it is associated with IOP. Another interesting thing is that caffeine, it also causes retinal vasoconstriction. So taken together, all these three things show that yes, the IOP intraocular pressure can increase, retinal vasoconstriction can occur, and also there is a dose-dependent effect, and probably the angle narrowing also occurs if you drink high caffeinated beverages. So the effect of this is also seen in this population-based study. So this is data from the Korean National Health and Nutrition Examination Survey. So they had 6,681 participants. In this study, they found that coffee drinking, especially in males, was associated with the primary open-angle glaucoma. Coming on, what is more alarming these days, and I noticed this a lot in Singapore, is that caffeine doesn't only come as coffee. So there are a lot of other caffeinated drinks which actually have doses much more than those were used in the study. So you can see these Red Bull and Monster Energy drinks, they have about 160 milligram of caffeine per can. And the youngsters these days, especially those working in the IT sector for long hours, are used to consuming a lot of them. So especially in that group, we should specifically ask if they are having caffeinated beverages if we find subjects with uncontrolled IOP. However, tea and coffee drinking in large population-based studies have also been found to increase risk of cancer. This has been mostly attributed to the effect of hot coffee and hot tea on the GI tract cells. So that's why it's very important that when we recommend anything to our patients, we should be very careful, because as we know, our patients can interpret what we say in myriad ways. Coming on, I'll talk about meditation now. So meditation, and especially mindful meditation, has been recently a very hot topic for study. So mindfulness meditation basically can be simply done by a Apple Watch. They have this Breathe app, and it has been shown that meditation can help in glaucoma. So especially this study from Dr. Dada's group in Eames, they showed that between the meditators and the non-meditators, there is significant reduction in intraocular pressure. There is reduction in the stress hormone cortisol. The oxidative stress, it goes down. The brain-derived neurotrophic factor goes up. And also the quality of life scales improve after doing mindfulness meditation. Coming on, Dr. Dada's group also published this review. So this kind of brings all the information together, and he rightly attributes meditation as a polypill, because not only on the intraocular pressure, the meditation also affects other pathological pathways that can increase glaucoma progression, like the inflammation pathway or the glutamate excitotoxicity pathway. So overall, meditation is something that should definitely be considered in managing glaucoma patients. However, it's very important to understand that meditation should not be mixed with religion, or it should not be mixed with a certain form of following a certain group, because meditation has existed in multiple ways in different populations. So you can suggest whatever is more conforming to someone that fits your patient profile. So a very simple guide would be to just sit comfortably, breathe in and breathe out at a relaxed rate, to close your eyes and to basically just look within. So this is a very simple guide to starting out. Moreover, however, we have to understand one thing, that all of these suggestions for our patients have to be taken with a grain of salt. They are always going to be patients who are going to have disease progression, and we should be very careful that we are not prescribing these as medications. These are small lifestyle changes that are always in addition to the glaucoma treatment that is going on. So it is very important that we listen to the patient first and then advise. Consistency is always the key for management of chronic diseases, and alternative suggestions are not standalone. IOP control is still the gold standard, and it is essential in glaucoma management. So with that, I would like to conclude. And 21st June is celebrated by the UN these days as the International Day of Yoga. And so again, this is something that yoga and meditation are being recognized all over the world for their health benefits. So I definitely advise everyone to have a look at it. Okay, thank you.
Thank you, Dr. Thakur. I don't see any questions. We'll open up for discussion for a few minutes. In the chat and the Q&A, I don't see anything there. So I think we can actually conclude our session.
Yeah, I think we are well in time. If no one wants to ask, I'll ask something. So Sanushka, how are the outcomes in the patients that you showed us? Do they manage to retain some vision in most of them, especially for those with superficial trauma? Or do they get infected as well later on? Because with the whole tropical weather there, and the amount of penetrating injuries that they have, like, do you have post sepsis or things like that? Because that is something that we see very commonly in India. So they would come with a small trauma, we would try to do a primary management, then the sutures, they tend to open up, they don't take care of it, and the problem becomes even more complicated.
We definitely have the same problem in these kind of rural settings, especially when someone has a decent prognosis and you've just done a nice corneal laceration repair, and they just don't come up with follow-up, and then you see them a month later with endophthalmitis. So it's definitely something that does happen out there. Generally, with all the simple corneoscleral lacerations or lid lacerations, they are managed on site at the Nelson Mandela Academic Hospital. But anyone requiring sort of serious orbital work or reconstructive work usually would get sent to Port Elizabeth or East London, which are sort of the nearest bigger centers, to be managed there. But the main problem with these areas is delayed presentation. If it's not something that is happening sort of closer to the hospital setting, you generally see them a week or two after they've actually been injured. And a lot of them end up with eviscerations or enucleations as a result.
So I think for all countries which have a large rural population, rural unemployed population, so we kind of face similar challenges. It's unfortunate, especially when you do a good repair and you kind of see that, yes, there may be a little hope, and then due to either patient not being cooperative enough or due to some other form of infection that kind of persists, it becomes very difficult to manage sometimes.
The other thing that I actually saw quite a few times is you repair the eye nicely and then they come in again with trauma. And then it's a ruptured globe because they've been injured in the same eye. So there's really, you see all kinds of strange things in these areas and you try your best to help and fix them. But I think there's a lot of social problems in those areas. And that's, I think, what needs to be sort of addressed in terms of preventing these kind of injuries.
Yeah, I think the solution for these problems, instead of being ophthalmology, is more of social work, counseling, and trying to especially control alcohol sale to youngsters, because I saw most of them were actually young people, right? I didn't see the typical elderly pattern. So in India, the pattern is slightly different. We would find somewhere people in the age groups from 40, 45 and above. Youngsters in India, definitely they have more of road traffic accidents rather than ocular trauma.
Yeah, it's
so
the
how
opposite.
about the demographic profile there?
It's actually strange. In these rural areas, you'll actually see the elderly are the working class. Most of these households, like I said, are run by middle-aged to elderly women. And they are the ones bringing the income in. And the youngsters are just not completing school, trying to get jobs. But when it comes to weekends or after hours, they're drinking and partying and hurting each other. And it's something that, like you said, it's a social problem. There aren't jobs available in the areas. So this is what happens. And it's driven obviously by poverty, and alcohol is socially acceptable, it's accessible, and you just need your 20-year-old friend or 18-year-old friend to buy you a beer as a 16-year-old, and there you go, you know.
Yeah, I think we don't have any more questions. So yeah, we can close the session, I guess. Chris, anything from your side?
Nothing on my end. I'm okay. It's good.
Yeah. Okay. I think then we can close the session. So thank you, Cake and Pie Expo. Thank you, Mice Media. I think the future is going to be like this. We are just going to have virtual conferences, at least for the next 2-3 years, till the pandemic goes away. But again, I think this is an excellent way to at least keep the communication going.
Thank you, Dr. Thakur.
Thank you so much.